Happy New Year from CAEP. My name is Kirsten Johnson, and I am the president of CAEP, and it's my extreme pleasure to welcome you to the first of our 2021 CAEP National Grand Rounds. Tonight is going to be an excellent session, and I won't take much of your time or the speaker's time, and I will let our esteemed colleague Jennifer Bryan introduce everybody, but I just wanted to take a moment to first of all thank you for attending our Grand Rounds and to wish you all the best of health and safety as we continue to be at the front lines of this pandemic, and all of us continue to work hard, and it's long, and it's been a good fight, but now we have the vaccine on the horizon, and many of you have also been recipients of the vaccine, so that's great news. And you know, we've seen a lot of changes in this last year, 2020, because of the pandemic, and one of the big ones is, of course, that everything has gone online. And so part of why I wanted to also just give a little chat with you tonight is to let you know about all of the cool stuff CAEP is doing to continue to provide a great service to our members, and give you a lot of exciting virtual and online content. And I just wanted to let you know that in addition to our Grand Rounds, which will continue, we are currently offering them twice a month, and they'll continue on as such, that next week we'll start a feature CGEM at the start of our Grand Rounds, because CGEM is also online, and we have a terrific new online version of CGEM that I would encourage you all to check out. And so the format for Grand Rounds going forward will be that we'll start with a little snippet, an audio file or video file, I should say, from CGEM, either the editors or the authors, just to keep you up to date and to encourage you to also go check out the online version. We'll be starting a new series hosted by Dr. James Miscolic on the changing face of emergency medicine, which will feature a bunch of big thinkers in a sort of a casual discussion chat-like format, talking about how emergency medicine is changing, and thoughts on how we'll move ahead with this new era of emergency medicine. We'll be doing a campaign called Humans of the Emergency Room, and we'll feature you and your faces on our new campaign to sort of get the message out that we are our members, and that includes all of you across Canada, no matter how far flung you might be. And so that's something that you should keep your eye out for. Our conference this year will be virtual, and it's going to be out of this world. We already have a wonderful academic symposium and a whole lineup of wonderful speakers, and I won't belabor that point, but just to say that I would really encourage everybody to attend, just because there's no travel makes it even easier. And then finally, we continue to do a lot of advocacy, and we will be releasing a press release to support our pregnant and breastfeeding colleagues who are right now not able to get the vaccine for COVID, as well as a number of other campaigns and things that are ongoing. So I would really encourage you to stay connected, attend our Grand Rounds and our other events, and let us know if there's anything else, any good ideas that you have, because we really are a product of our membership, and we're here to support you as we move forward. So stay safe and healthy, everybody, and I'll hand it over now to Dr. Bryan. Have a great session. Bye.
Thank you so much, Kirsten. Welcome, everyone. Our work here today is in the spirit of moving forward toward reconciliation and anti-racism through patient-centered care, and we'll begin with a land acknowledgement. To recognize the land is an expression of gratitude and appreciation to those whose territories we reside on. As we gather today in this virtual space, we acknowledge and pay respect to the many First Nations, Inuit, and Métis people and their traditional territories on which we live, work, and play. I'd like to acknowledge that I'm speaking to you from the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and I'm grateful to have the opportunity to live and work on this land. I'm Jennifer Bryan, an emergency physician at the University Health Network.
And I'm Nia Navarro, a registered nurse at Toronto General Emerge, currently working in First Nations communities in Northern Ontario. And we're founding members of the Sickle Cell Working Group with UHN Emergency Department. We're grateful to be joined today by patient advocates and healthcare providers for this important conversation. Our speakers tonight are Euless Guerrier, who is the Director of Patient Support of the Sickle Cell Association of Ontario and co-founder of the UGMA Sickle Cell Emergency Fund. Marianne Gordon, who is a single mother of 2 daughters, the oldest of whom is now 10 years old, who was diagnosed with sickle cell at 7 months. Marianne is a member of the Sickle Cell Awareness Group of Ontario's Patient Advocacy Council. Joining us for our panel will be Dr. Madeline Verhofsik and Dr. Isaac Odame, hematology leaders in sickle cell advocacy, and Serena Thompson, a patient advocate and vice president of the Sickle Cell Association of Ontario.
CAEP's Scientific Planning Committee has reviewed all participants' declarations of conflicts of interest, and no conflicts, perceived or real, have been identified. There's been no external support received for this webinar. By the end of this session, participants will be able to recognize the importance of objective and subjective treatment targets in caring for patients with sickle cell disease in the emergency department, identify pain management coping strategies, and begin to explore how to support non-pharmacological adjuncts to pain management for patients with sickle cell disease. Begin to examine barriers to care for patients with sickle cell disease in the emergency department, including stigma and anti-Black racism. The second half of this session will be dedicated to question, answer, and interactive discussion. Please post your questions for our panelists in the chat. At the end of the session, please complete the evaluation so that CAEP can continue to bring great content through these National Grand Rounds. The link will be posted for you in the chat. The webinar certificates will be mailed out on Thursday. So what is sickle cell disease? Sickle cell disease is one of the most common inherited genetic disorders. In Canada, many of those affected in Ontario are in Ontario, but we know that there are people living with sickle cell disease right across the country. Sickle cell disease affects people of all races, though in Canada, most of those affected are Black. It continues to be a high morbidity, life-threatening disease. There are guidelines that can help standardize practice, including the Clinical Handbook for Sickle Cell Disease Vaso-Occlusive Crisis, which was a joint effort of healthcare workers and patient advocates, including 2 of our panelists tonight. It includes clear recommendations, including triaging patients with sickle cell pain crises as a CTAS-2, and key targets, such as initiating pain management within 30 minutes of ED arrival. Early pain management is necessary not only for patient comfort, but can also decrease rates of hospitalization. By standardizing care, believing our patients when they tell us how they feel, and prioritizing early pain management, we can dramatically improve the care of patients with sickle cell in the emergency department.
The historic and recurrent practices of violent medical racism and exploitation are abundant and are directly relevant to sickle cell care. Many of us are aware of this happening in America, but as the racial discrepancy in the rates of COVID-19 infections have demonstrated, anti-Black racism in health is also a reality in Canada. This creates mistrust and poor health outcomes for Black people for generations. Acknowledging this makes us more aware of the conscious and unconscious ways racism still exists in our healthcare system. Sickle cell disease is often compared with cystic fibrosis and patient experience, both being genetic degenerative diseases affecting one's quality of life, both affecting about 5,000 Canadians. The difference is that one is thought of as a Black illness and the other a white illness. Estimates are that cystic fibrosis receives more than 3 times research funding as sickle cell disease. Accepting the role of race in this is crucial. Serena Thompson, a patient partner member of our working group and one of our panelists tonight, wrote in the Canadian Medical Association Journal, "My relationship with the emergency room is that there is no relationship." Building relationships can have a profound healing on patient outcomes. Connecting with patient advocacy groups is important to support patients and fill the continuity care gaps after discharge. These institutional and structural racial hierarchies reinforce the inequitable treatment of our patients. Racism is a social determinant of health inequity because of the multitude of ways it can lead to poor health outcomes. This is a patient safety concern. We can focus on prioritizing ethics of dignity and respect, choosing an approach centering the patient and their family, listening and creating an environment where the healthcare team and patient are in partnership. Many of us have heard about the identifiable factors precipitating sickle cell crisis, like cold weather, dehydration, and illness, but stress, trauma, and anxiety are also triggers for crisis. The stress of racist perceptions and stigma literally keep our patients sick. Sickle cell disease patients who are seeking care have the added layer of stress, having to think about how they will be perceived by the healthcare workers receiving them. Many feel burdened by respectability politics and will dress up nicely as a strategy to avoid judgment or to be seen as worthy of care. In the same way that we don't say addicts, sickler is an offensive pejorative, dehumanizing the patient by their disease. In a 2013 study, healthcare workers identifying their patients with this term resulted in negative attitudes towards them and a lower quality of care for patients in crisis. Sickle cell disease patients' pain is often dismissed if they're not performing pain in a way deemed appropriate. There are many behaviors and coping strategies used by chronic pain patients as distraction techniques. And patients with sickle cell are experts in managing their pain. So if a patient in pain crisis is asking for food, or is talking on their phone, or is pacing, or requesting a warm blanket, these aren't signs that they're feeling better. In many cases, these are ways that they're trying to manage their pain and could actually be signs that they're feeling worse.
Like Nia mentioned, patients hear when we use stigmatizing language. They hear when we call them drug-seeking or opioid dependent. A study in the US showed that most emerged physicians thought that at least 20% of patients with sickle cell use opioids for reasons other than pain management. In reality, the number is very small, less than 2%. It's clear that patients with sickle cell disease aren't driving the opioid crisis. There's no emergency department investigation that can confirm that someone is having a pain crisis. We just need to believe our patients and remember that pain assessment is a high-risk area for implicit bias. 3 key points that we'd like you to keep in mind as you listen to our speakers tonight. The first is to consider the ways in which language used in your emergency department when speaking about patients with sickle cell disease might impact their care, and the ways in which their experience might be affected by stigma and anti-Black racism. The next is to think about what procedures are in place in your emerge to ensure that you're working toward accepted standards of care for patients with sickle cell disease. The third is to think about ways your emerge might benefit from input from patient partners in optimizing care. Now we'd like to turn the floor over to Ulysse Guerrier, who is the first of our patient advocate speakers tonight. Ulysse.
So good evening, everyone. So today I'm going to be talking about my story and my experiences in the emergency department. So I was diagnosed with sickle cell beta thalassemia at the age of 2. And my family had 5 children, and my parents have lost 2 children to sickle cell disease. I've been taking since the age of 6 years old. I was diagnosed with a Dr. Yvette Boni, that some of you might know. She's a staple in the hematology in Canada. And she's been using me as a case study to teach other doctors what sickle cell is and the presentation of sickle cell in individuals. So I've been doing that since the age of 10. So the standard of care in the emergency department for sickle cell hasn't very changed in, I'll say, in the over 20 years. Typically what we do is to have a blood test, like a CBC, a blood test done for an individual that has sickle cell disease, provide IV fluids, provide pain control, oxygen, and if we can do that inside of 30 minutes, that actually helps reduce the amount of time that a patient with sickle cell disease stay in hospital. So what do patients want doctors to know? Sickle cell disease, like Dr. Bryant spoke to you guys earlier, is a lifelong condition. So it's inherited. We have it at birth. And often some doctors ask the question, like, when was the last time you had sickle cell disease? Those are, if you know what sickle cell disease is, that should not be a question that should be asked to a patient. We need to be screened as an emergency and be treated as such. So what I mean by that is when we come into triage to emerge and we said we're having a sickle cell crisis, and usually the nurse will put us, like, there's a code in the emergency department. As an example, let's say code green, code orange, and code red. So we usually get screened the right way, but it's not reflected in the right way, in the sense of, like, the nurse will not go to the doctor and make it a pressing situation. So that's something that we would like to see change. So we want healthcare providers to listen to us and to take us seriously. When we say we are in pain, what our pain is it what we say our pain is, it's what it is. It should not be questioned, and especially in the emergency department. This is not the place to question if we are, like, drug seeking or etc. And as an outside patient, we can take time to do that, but not in the emergency department. So we would like to be listened to. We would want the healthcare providers to have empathy and to understand that it's a very painful condition, and also to take the color out of the healthcare. What I mean by that, it's like we usually present, as an example, for myself, I've never been in the emergency department besides going in an ambulance and wearing, like, as an example, PJs. I'm usually dressed as you guys can see me here, and you always try to present yourself in the right manner so that we don't get stigmatized as drug seekers. So that's the reason we say, like, it'll be good to take the color out of the healthcare. So racism is something that we all face, unfortunately, but with more information, and as you guys understand what we go through, we could reduce those bad experiences. So in 2007, I went to a hospital for a vaso-occlusive crisis, a sickle cell crisis. I got triage, had a fever, my blood pressure was high. So presented with a lot of pain. I usually, what I take for my pain is fentanyl. I got fentanyl patch. It goes to 75 micrograms to 100 micrograms every 72 hours. So when I'm using fentanyl at home and it's not working, and when I go to the hospital, at that point I would need more pain meds than what I'm actually taking. So I went to the emerge, got triage. I was waiting in the emergency room for over 3 hours before I got brought inside. So we waited for an hour with the doctor. So when the doctor came, asked me, like, what I came for. So I had a sickle cell crisis, didn't really read my chart. So to start, he wanted to give me 25 micrograms of fentanyl. And then he said, like, he'll come back in another hour to check up on me and then see if that works. So if I'm taking 75 to 100 micrograms fentanyl as a patch, getting 25 micrograms IV even, it's not doing much to the pain. And the concern most of the doctors usually have is that they're not comfortable giving us high dose of medication. But if you understand that I've been taking narcotics since the age of 6 years old. Now at 44 years of age, my body is tolerant to narcotics, so I can take more medication than the regular population. So I've been waiting for so over 4 hours. By the time I got some pain meds, so I had to have the nurse to advocate on my behalf, to speak to the doctor so I can get proper pain management. So in this particular case, I didn't know the nurse. I don't know like the staff at the hospital. So it took longer for them to really, like, take care of my of myself, of my pain, and of my crisis. So having, like, our nurse, it's usually the first line of support that we have. Having a relationship with the nurse usually help, so that they can understand what we go through and they can advocate on our behalf to the doctors. So in this particular situation, my care went from bad to worse, and I end up in ICU. The reason for for my crisis to end up being worse, it's with sickle cell disease. Things can happen, like, very quickly. We can have underlying issues. As an example, we can have pulmonary embolism, which was one of the reasons why I ended up in ICU. I went in. They do a chest X-ray, as an example. The first chest X-ray could come out clear and with no issue, and then a situation get worse. And by the time you do the second X-ray, the condition, get worse very quickly. So to summarize this, it goes very the change in the way that our condition can happen. It goes very quickly. So that's the reason why we need to take those things very seriously. Another example I would like to give you is, I had another bad experience. As an example, I broke my wrist. To explain that the pain that we go through, we're so used to handling pain. So I broke my wrist, and I felt like the pain wasn't like a lot. And when I went to emerge, when they saw my hand was swollen, the reaction was very immediate. The nurse came right away and wanted to help. They wanted to give me pain medication, because they saw the way that my hand, like, was very swollen. The impact was, like, visible. It's something that you can see. But when we go in with a pain crisis, it's something that you cannot see. So the reaction is usually it's very different. In terms of good experience, went to a hospital, to the regular hospital that I go to. I have a good relationship with the staff, with the nurses. So I got in. The nurse knew me, knew my history. I went in like as soon as possible. Inside of 40 minutes, I got my pain meds administered. I got IV fluids. I got oxygen. Got my blood taken. Sorry. So thanks to the nurse that knew me from years coming to the hospital, I got taken care of quickly. So and also wanted to explain that in general, this protocol that are in hospital, it's something that can be done anywhere. I had a good experience in hospital. I had bad experience, and I also had, like, VIP experience treatment. I went to the United States, and so inside of 30 minutes, I got pain meds, I got IV fluids, I got oxygen. I was in and out, like going in, and being in a ward. That happened very fast. So I know it's something that's durable, and it's something that we can that could be done in pretty much every hospital. It's a question of having the will to be able to make that happen, and then the knowledge on how to. So thank you for your time. Thank you, Dr. Brian, for having me. And if you guys have any questions, I will take your questions at the end.
Thank you so much, Ulyss. Now we'll have a parent's perspective from Marianne Gordon.
I'll be speaking to you from a mother's perspective. Sorry, okay. Just starting my timer. This is my daughter, Nevaeh. She is 10 years old. She's been diagnosed with sickle cell since she was 7 months old. I didn't know anything about sickle cell. There was nobody in my family that had sickle cell disease, and I knew no one with sickle cell. The only thing I knew is that it was associated more with Black people. So naturally, it was very gut-wrenching and devastating to receive that diagnosis for her. I immediately began to think about her life expectancy and quality of life. It was very scary to know that she could succumb and pass away early and not live to her potential because of this disease. What's life like living with sickle cell for Nevaeh? Well, she experiences frequent excruciating pain in her arms, her legs, and her feet, along with painful headaches. By the time she was 4 years old, she had undergone a splenectomy, which puts her at a higher risk for bacterial infection. So even before COVID, I always traveled with hand sanitizers and things like that, just because I was scared of her getting any kind of bacterial infections. She's had numerous blood transfusions, hospital admissions. When she goes, if this pain is really bad, then she has to get morphine. By the time she was 8 years old, she had already had a silent stroke. She takes hydroxyurea, folic acid, and penicillin daily. She's easily fatigued, and lately I've noticed that she's complaining more of chest pains and trouble breathing. She has to drink lots of fluid to keep her body hydrated, so she's very much aware the importance of water and how it can help her blood. There's always that risk of the acute chest syndrome, which is deadly, and the vaso-occlusive crisis can happen anywhere in her body, suddenly without warning. Naturally, parenting is a very challenging job, but when you add taking care of a child with a chronic illness, it becomes even more daunting. There's a lot of stress and anxiety and fear due to the unpredictable nature of the disease. It's very emotionally devastating to see your child suffer and scream in pain. There's been many times when I've been in the kitchen making dinner and she screams out the most horrific scream you can imagine, and I run to her and I can't even touch her sometimes because she's just in pain. And I'm wondering, is this going to be a crisis that's short, or are we going to end up in the hospital? So it's very unpredictable. There's the immense feelings of helplessness, despair, sense of guilt that you caused this on your child. I never leave home without any painkillers. I always have Tylenol and Advil with me in my purse in case something happens and she needs pain medicine right away. There's relationships with other people are affected. I have another child who's 7 years old, and there's times when I know that I can't spend as much time with her because I have to take care of Nevaeh. And I know that she can feel neglected, but this is what it is. So along with that, you're combating feelings of isolation as a parent, because only someone who's going through the same thing can understand what it's like to take care of a child who's got a chronic disease. So I also have to cope with her self-esteem and make sure that she's keeping strong mentally, and also that she doesn't stress out, because I don't want her to feel like she's different from her classmates. Children with sickle cell disease can often miss a lot of school, and they risk falling behind academically due to hospitalizations and painful crises that they have to manage at home. And this can lead to them being labeled falsely as lazy or underachievers by teachers. It's very difficult to be thinking about academics when you are in pain. So along with the emotional stress and anxiety that comes with being a caregiver is the economic impact that's on families. So Because a pain crisis can last for hours, days, or even weeks, I have to sometimes take time off work, or I have to leave work early or stay home with her to take care of her. Thankfully, I do have an employer that's very understanding, very accommodating and sympathetic, and knows what I have to do in order to take care of her. And I know this is not the case for many parents. Sometimes we're not able to take the promotion we want because we feel we may not be able to do our jobs to the best of our abilities because time is required to take care of our children. So even the activities that we plan, I can't take her on long flights. The most she's ever gone is 4 hours. So I choose to live close to the pediatric hospital that she goes to now because I'm honestly very scared to take her anywhere else because I just don't feel she'll get the care that she's getting now. Since there's no cure for sickle cell disease, we have to do what we can to prevent crises, which is keeping our children away from too hot or too cold temperatures. Even going in the lake can be very, very dangerous for her. So she doesn't go outside for school if it's colder than -10 degrees. Every year I ensure that any teacher she has, that they're given all the information that they need surrounding sickle cell. So if she is in crisis, they know exactly what to do. So I make sure the school has a protocol in place so they can call me if anything happens. I keep a constant supply of pain medication at her school. So on average, about 3 to 4 times a week, I do get a call from the administrator saying that they had to give her pain meds. So this care plan that I have at school is very essential for her well-being. Nevaeh, currently she's seen at a pediatric facility. She's been going to the hematology clinic there since she was 9 months. So she has a crisis and I take her there. Our experiences have been great. This hospital is amazing. The staff is very knowledgeable, all the doctors, all the nurses. She's immediately triaged within 20 to 30 minutes. If she's assessed for her pain, she's given IV fluids. If Tylenol and Advil aren't suffice, then she's given the morphine that she needs. So I'm listened to. As a parent, I feel reassured. The ER physicians, they communicate with the hematology specialists at the hospital as well. So it's very collaborative. Like I said, everyone's knowledgeable, very attentive to my needs and her needs. And because of this protocol that's in place, I can lower my stress and anxiety and just focus on getting my daughter through her crisis. So this is what my goal is that every hospital, this is a mother's wish, and also as an advocate, that every hospital in Ontario has the same protocol, that there be no inconsistencies, and that my daughter doesn't have to go through the same experiences Ulysses just described to you. So I just want, hopefully by the time she transitions from pediatric care to adult care, that these stigmas and racial stereotypes, negative attitudes towards sickle cell disease patients are eradicated, that we can have a protocol, not just in Ontario, but nationwide. And it's through forums like this and educational sessions that I think we can get this started. So I'm very happy to be here tonight. Thank you.
Thank you so much, Marianne. We're going to move now into our discussion session. So if you have not yet posted your questions in the chat, please go ahead and do so. A reminder that we've got patient advocates, we have hematology experts, we have eMERGE team members all here on our panel to be able to talk about some of the challenges that have been discussed so far. And just a note that there are almost 100 registrations for this session, which I think is very exciting and means that there are 100 emergency medicine team members across the country who are able to hear the stories that are being shared tonight. So maybe we can get started with a first question to Serena Thompson. Serena's portrait in the Canadian Medical Association Journal was mentioned by Nia earlier in this session. And Serena, just listening to the stories from Euless and from Mary Ann about her daughter, what are the things that you would like emergency physicians and nurses to know when you come in to the emergency department in order to give you the best care possible?
Well, thank you, Dr. Bryan, for the question. And I want to thank CAEP for inviting us on this very special evening. I'm very glad that we're able to, have a conversation about sickle cell. And for me, what I would want someone to know about me is that first, I'm human and wish to be treated as so. So once I do show up at the ER, you must understand that possibly by that time, the pain has been excruciating for a couple hours, or I try to, manage the pain at home. But by the time I am showing up in the ER, I am not there to get anything else but pain relief. And, when we do come in and say that, my pain is 10 out of 10. It's really up there. It's unbearable. We do wish to be treated. We wish to be heard and believed as well. And then that way treatment can go on and, swift, prompt, quality care can happen. And then also what I would love, the healthcare professionals or whoever I come across know that I am not a druggie because of the dose of opioids that I need for the pain to even start diminishing. That's one thing as well. When we come in, drugs is the last thing that is on our mind through our daily lives. We're already taking it every day, multiple times throughout the day. And then, have to worry about taking an hour before something else, 2 hours after eating, but don't mix it with this medication and that medication. We're already going through all that. So then when we come into the ER, we are not drug seeking. We just want pain relief. And that's really it. And then second, why not create a system? Why not create a system where emergency info is listed under us, like in our, I guess, if you even swipe our health card or something like that, the emergency info is in there, our doctor's information is in there, the protocol's in there, and so on. I don't know, come up with a way that we don't have to keep repeating ourselves every time we come into the hospital, and especially for a way to somewhere else. We may not be going to our same hospital all the time. We could be out of the country or in the country, but at a different location, a different hospital, and so on. So if that information was available, that would help tremendously reduce the time of figuring out what to give us and who to talk to and so on. So that's what I wanted to say with that question. Thank you.
Excellent. Thank you so much, Serena. Just following up on Serena's comments about the things that would make care smoother for her and for others coming into the emergency department. Dr. Madeline Verhofstadt and Dr. Isaac Adame, who are on our panel today, you were both co-chairs in the creation of the clinical handbook for sickle cell disease vaso-occlusive crisis in 2017. That's been such a guide for hospitals in establishing protocols for managing sickle cell complications. Can you speak to some of the suggestions in the handbook towards minimizing the barriers to the kind of care that Serena is talking about?
Absolutely. So I'll start, and I'm sure Dr. Odami will have much to add here because, of course, it's a huge topic. And Euless and Serena and Marianne have done an amazing job of giving us the front line, the patient experience, the family experience. I think when it comes down to it, I think of the barriers as being really divided into three main categories. Sometimes it can be a knowledge issue. Sickle cell can, in some communities, be a fairly rare condition. And so depending on where an emergency department staff is, which emergency department they're in, they may not have a lot of experience with the patients coming through. So, I mean, anyone who's tuning into this session is already taking a huge first step in starting to address that knowledge gap, just the understanding of what is sickle cell, understanding that although the pain is invisible, these are literally cells that have changed shape and are getting clogged deep inside the bones where this ischemic pressure builds up. So it's this deep, deep pain, and understanding that. I think other than that, another major barrier that we've heard time and time again can be, but is thankfully not always, just provider attitudes, right? Whether it's overt or maybe underlying racism that somebody doesn't even realize because of the way that our society is structured. I heard a term called cumulative deprioritization, which means, in a busy emergency department where you've got hundreds of patients flowing through every day, there are going to be certain people who may be demanding more attention, or who may intuitively, in the way that we view what the priorities are, rise to the top, and others who may sift themselves down to the bottom of the priorities. And when that happens, encounter after encounter, someone with sickle cell finds that they're waiting. They've been there for, as Euless said, 3 or 4 hours. So, that being a barrier, what's the counterpoint to that? What would be the enabler? Would be really focusing on that compassionate, empathetic, person-centered care. And I want to build on something that Serena mentioned as well, which is the fact that this care needs to be individualized. It may not be like where somebody comes in with a myocardial infarction and you apply a protocol. It's someone like Serena who may have a fairly high opioid tolerance and therefore a fairly high opioid requirement to address her pain. And so it's all in collaboration with the patient. It's not a slap up protocol on kind of a scenario. So it comes down to that relationship, trust, communication with the patient. And another, lastly, which Serena mentioned at the end there, and is very important, and we all have to think about. So, we've got the individual interaction, our individual responsibility for knowledge, but there's also that higher level initiative of quality improvement initiatives where we can develop order sets, roll out educational initiatives in departments so that we're casting a wider net so that we're addressing the problem on a larger scale. I wonder what else you have to add, Isaac.
Yeah, that has been very, very well presented by you. I think the very first point I want to make is that pain is a subjective feeling. You've got to believe what the patient is telling you. And one thing I want to draw attention to is that if you've lived with pain all your life, you automatically develop very good coping measures. So the fact that the patient is not screaming and jumping up and down and causing a havoc and seems to be calm, listening to music and trying to stay calm, doesn't mean they are not in excruciating pain. And if you are in doubt how intense this pain is, I know many women who have had babies, have gone through pregnancy, have had labor pains, and they think that sickle cell vaso-occlusive pain could be worse. So it's almost like a woman coming in labor pain, in intense pain, who is being ignored and asked to wait for 3 hours on the sideline before receiving pain medication. So that's the first point I want. We should never be deceived by how calm and cool they are. With children, you see them playing games and watching TV, and the nurse goes in there and said, "Oh, I didn't think the child had pain at all." That is not right. The second point I want to say is that apart from having acute exacerbation of pain, we do know that about 30% of adults with sickle cell disease live with some form of pain every day. And that's chronic pain, over which there may be an exacerbation. So when they come to the ED, it has gone beyond what they normally can bear, and they need the relief immediately. And that's why I think in emergency rooms, there should be a fast track. You see a sickle cell patient, you don't need complicated examination and assessment. You know that the first thing you can do is to relieve their pain. Often it's after relieving their pain that you can get a better history of what has been going on for a while. Relieve the pain first, just like you would do for a woman in labor or somebody who's had a fracture. So that's the point I want to add there, that we ought to believe the patients, we ought to trust what they are telling us. And that alone, being listened to and being cared for, is a big measure in making them feel confident that their pain will be controlled. They don't want to stay in the hospital. They don't want to be in the emergency department. And I think sometimes that's why they present very late. They don't come until it is something beyond what they can control. They have no desire to be in the hospital. They want to be controlled and get home and continue with their lives. That's what I'll add to that.
Thank you so much. I wonder about, we certainly do see times when patients' pain is discounted because they are, they're eating or they're on their phone, or like you mentioned, Isaac, with the child playing games who's still having incredible pain. Nia, I wonder for you as a strong advocate, a nurse in the Emerge, if you're working with colleagues who say, oh, they look fine, they're on their phone, they don't need more pain medication now. Are there ways that you've been able to advocate for patients in speaking with colleagues to try to address some of the knowledge gaps and maybe some of the stigma?
It's sometimes difficult, of course, because there's a lot of implicit bias for chronic pain patients, but specifically sickle cell patients that we see in our Emerge. At Toronto General in our Emerge, we have a protocol. So it's important, being in triage, to initiate the protocol early. So to go directly to a doctor and say this patient is in crisis. If you're working with a team, a lot of nursing generally is team nursing. Even as a triage nurse, if I'm handing this patient off, sometimes I would take our protocol and be like, this patient is in crisis, please speak to the doctor. Or, you advocate by ensuring that your partners are initiating these pain protocols faster. But it can sometimes be difficult to not, overstep. But it's always important to advocate for the patient, and especially somebody that's in pain.
Absolutely. So hopefully that's one thing that our participants tonight can start to do, if not already, to try to have those conversations with colleagues. There was a question from a participant specific to our patient advocates, talking about one of the things that can delay getting pain medication outside of the recognition of pain is being able to get access for medications. So difficulty in getting IV access. And so there was a question from the audience about how effective for you it is to start with non-IV approaches like intranasal fentanyl or oral opioids. And maybe I'll direct that to Ulyss to start.
Well, I would say for me, before going to the hospital, I will basically exhaust everything that I can do to manage my pain at home. And by the time that I get to the hospital to me, it's the last resort. So I'm literally like in a situation where there's nothing else I can do. Like, I will try like, heating pads. I will try deep breathing exercise. I will try taking my pains orally. I will double the doses. I will do like follow like, the pathology as it stands, but I will try to increase the dose because I know when I'm in the hospital, the dose is higher than what I'm taking at home. So I try to increase it to see if I can get some kind of relief. If that doesn't work, that's when I go to the hospital. So at that point, I cannot be taking the same amount that I'm taking at home. It's because what I'm taking at home is not working. That's the reason I go to the hospital. I hope that answered that question.
Thank you. Serena, any thoughts about that for yourself? So oral routes or intranasal fentanyl is something that that we've been hearing talked more and more about in the Emerge.
Sorry. Well, for me, I do the same thing. I can tell with my pain, it's different stages of pain. So when at the beginning, because most of the time my pain will come when I'm sleeping. So there's no time for anything. Once I wake up from pain, I need to go to the hospital. I know for sure I could take maybe one dose, a dose of medication at home, so I can move around at least, to pack my bag and be ready for the ambulance. But before now, my pain comes whenever. So once I start feeling something, I quickly take something oral, which is less dose or not as high as an opioid. So I'll take a Tylenol or an ibuprofen or both together, just to give me some, just to see if I am able to catch the crisis right at the beginning, because and not with my stronger meds, just something lower, just to see if that'll work. And so I try that routine, and then also if that doesn't work, then I go to my opioid, and if that doesn't work, then yes, I go to the hospital. But that is obviously when I can't get any relief. The pain is so intense to a point where I know I have to go, or else something's going to happen. But all of that time could have been 2-3 days. And really, I could have been, if I know that I can go into a hospital, ER, and be treated right away to the point where I don't get admitted, then I'm home the next day, or I'm home that same night, and I'm back to normal. Most of the time I can recover at home just fine. Take my time. I have I have my daughter, so she knows what to do. She's old enough to take care of me. So, I'd rather be at home. That's the place that we feel most comfortable. To me, it feels like we're bothering people with our illness. Like we're bothering people. Oh, I have to call my dad to pick me up. Now I got to get somebody to babysit. Now I got to, you know, call this person, let them know I'm in the hospital when I don't want the whole world to know. My sister will tell everybody, you know, like stuff like that. So it's, you know, a lot of things can be, reduced. A lot of time can be reduced if we knew that we can go straight to the hospital for relief, and so that we can continue our lives, as Dr. Adami said.
Thank you, Serena. And Euless, I think you wanted to add another point there as well.
But I think one thing I want people to understand is that we don't want to go to the hospital. Like, this is although the hospital is like almost like my second home, I don't want to go to the hospital. Like, I would try to do anything possible not to go to the hospital. So by the time I go to the emerge, I'll probably be in pain for like 3 to 4 days, like consistently, and I don't see anything getting better, and that's when I go in the hospital. And I'm saying that to the staff that are doctors that are listening right now, this is not something that I would advocate for other sickle cell clients to do, right? Because we want them to go as fast as possible. The faster you go, the shorter the stay in the hospital can be. And this is where, like, it's a vicious cycle. You go in the hospital, you wait in a long period of time and emerge. A lot of time you get mistreated. So it ends up being like, it's not a place where you want to go in the first place because of the experience. Now you add the aspect of the faster you go, the better that they can take a handle on your pain, the shorter the stay is, and the shorter it is for you to recover. Like, everything in the ideal situation, you start having a crisis, you go to the hospital, they take care of you right away. You end up being home in 2 to 3 days. But in most cases, because I'm waiting, this is my last resort. I've been in pain for 3-4 days before. I go to emerge, I'm waited, and that extended the amount of the time that I'm waiting, and something else can happen. Like I was saying, like, you know, I got ambulatory pulmonary, I could have an infection. Like things, you guys, Dr. Verosek and Dr. Odami, you guys can talk about that the situation can change from bad to worse in a short period of time because we don't know. And the fact that you're having blockages in all areas in your body, your organs can be damaged. Different things can happen. Like, I literally have experience where I went in the hospital for a crisis. 2 minutes ago, I was talking, having jokes with the staff, having a good time, and 2 minutes later, I'm coding. And I cannot explain to you what happened. The doctors cannot explain to you what happened. And this is things that we deal with. But if in a situation where you can handle the situation quickly, we can reduce the complications. So that's one thing I want to. Dr. Verosek and Dr. Tony can maybe elaborate on the fact that things.
Well, I think I'll come in here because I think it is important for us to understand that pain is not the only manifestation of sickle cell disease. In fact, there are some patients with sickle cell disease for which pain is not prominent at all. However, when they come in painful crisis, they are at a high risk of organ failure. And I think what Ulysses was trying to describe there is the high propensity to develop acute chest syndrome, which is a major cause of mortality. So when the patient is screaming in pain and is being ignored, you may go in 30 minutes or an hour to see a moribund patient who is virtually struggling with his breath. And that's because they can develop acute chest syndrome, white-out lung, and this could happen before your very eyes, even after you've had a normal-looking chest X-ray. So sickle cell patients are at risk of multiple, and I want to emphasize here, it is a chronic inflammatory endothelial disease with multi-systemic complications, from the brain right down to the bones and joints. Every organ can be affected. And so I would like my emergency colleagues to pay a little respect to sickle cell patients because they can deteriorate very quickly. And I'll give you an anecdotal experience I had. I was interviewing for a job at Sickle and met the head of intensive care. And he told me in a very, very terse attitude that the patients he gets most scared of are the sickle cell patients. When they come to ICU, he knows that he can't keep his eye off because they can deteriorate so quickly. So when they come in with pain, always think, there could be something behind that. I better take care of them, because when we have seen prominent cases happen in the emergency room, it's because their sickle cell pain has been complicated by organ failure or other complications, as was the case when Ulysses went to ICU.
There were a couple of questions about is there a protocol set in place for sickle cell patients about carrying medication out of the province and out of the country? Is there something that exists? I have no idea.
Yes, there's a protocol. Yeah. Usually we'll send patients with a letter just so they don't get harassed, so that it's clear that what's the bottles that are in their bag are what's on the list. Yeah.
Okay, excellent.
I did not know that.
We're all learning something tonight. The other question was comparing the national approach to sickle cell to other blood disorders like hemophilia. And so there was a question around, has there been a thought nationally about having cards similar to what patients with hemophilia carry, to say, this is how you start my treatment if I'm having trouble?
Would you like to take that, Ulyss?
We're working on it.
No, but you know what? We did try that one time. Did have a hematology doctor. He made a book that was tailored for each one of us, and separately, individually. And then he's like, he'll write. He would basically write our own protocol in our book. And he would put his phone number, his fax, like all his contacts are in there. And so then I remember when I had my book, because I realized the hospital I was going to didn't have the protocol anymore. I showed them my book. They didn't even want to touch it. They didn't even want to look at it. They didn't want
it's not well received.
They didn't want anything to do with it. And I said, but my information is here. My doctor's number is right here. He's giving you permission to call him. You know what I mean? It was so simple, but they were like, no, I don't want that. I want to look at it, nothing. It was so weird.
Even inside of the same hospital, they still have those same issues where you can have a protocol. It's in actually the system. It's on the computer, and some doctors, they don't even want to take the time to go and read it. So that's the reason why it's hit and miss. But I guess if we can have a universal protocol put forward, which we're trying to accomplish, once that happens, that might be able to be easier to have each CEO of each hospital to be able to push that forward to make it implemented across the board. That's the hope, right?
The thing about the card is an interesting one, because I think within hematology, many hematologists who do sickle cell care also do hemophilia care. So a lot of ideas from hemophilia got brought into sickle cell. For whatever reason, mostly it seems as though it's individual centers that have done the card-based approach where they'll give it to the patients. I think it's a bit hit or miss though, because just as Ulyss and Serena said, we have cards. Our patients are given cards. It's actually business card size. It's double-sided, but it folds open, and it has their whole medical history, their medications all listed inside, and it has information on the back about how they should receive their treatment. And a lot of patients tell me, yeah, they didn't want to look at my card when I went to the emerge. Triage didn't want to look at it. And it's very official looking, right? So CANHEME, the Canadian Hemoglobinopathy Association, which Isaac actually founded, and I'm a board and exec member, for many years, they do in fact have cards that centers across the country do have, that have that similar information on it. So, you know, paper cards have some benefits and some drawbacks as well. A lot of people don't carry wallets. And so ultimately, I think the holy grail will be when we have an electronic system, right? That's kind of a national system where you just, and hemophilia is way leap years ahead of us on that, where there's a national system where you can just log in the person's name and pull up their whole file, their dosing,
Wow.
etc.
Yeah, so I guess that's what I was just asking.
So would there be an issue with privacy, with the privacy laws and things of that nature? Because that's always been the roadblocks that we face, is that when we're trying to access information, this is the first thing the doctors will say is like, with the privacy issue, we don't want to, they cannot disclose certain things. How do we get around that? Because I was thinking about putting up an app, because everybody has a phone nowadays. So if you can create an app that could alleviate that, I think that would be helpful. But the main issue with the app is the privacy issue. So that's my big problem, trying to fill that gap. What is the solution to that, in your opinion?
Yeah,
Well,
I don't have a solution. Isaac may. I can say that the hemophilia one is only accessible to certain people, right? Not anybody can access it, and I think privacy is a really serious concern, because if you have a breach, it's a big problem. But we've got to be creative and try to find ways where privacy isn't a barrier. Go ahead, Isaac.
Well, I think the one fundamental difference is the big R word. It's racism. And we've got to name it and call it what it is. If this was a white disease that is mainstream, people come in who are known in the community, important people, all these excuses will vanish. And there is evidence, literature to show that in the area of fractures, that if you are white and you have a fracture, you're more likely to receive an opioid than if you were Black. So these are the undertones of racism that often plague our systems. Why is it that data that has been generated by an expert on his own patient is not being believed and not utilized? It would be unthinkable, because the fact that they don't even consider what you're saying seriously. They don't think you're knowledgeable enough. And I think these are the things that I think our advocacy groups, I think it's high time you included these issues in your advocacy, because it's the bias and the preconceived notions that poses these barriers, and even believing what you're telling them or showing them something that would be helpful. The challenge with sickle cell disease, as Ulysses did outline, the protocols can be different for each patient. Particularly, I didn't say during this session, but the frequent visitors to ER are only a small percentage of the patients. So data shows that about 2.7% of patients in the United States account for 27% of ED visits.
Even in the handbook, you guys mentioned that as well.
Exactly. So by the time they've been coming frequently, each patient has what works for them.
Yes.
So a simple question like, "Oh, Serena, what works for you?"
Yes.
Or Ulysses, "What works for you?"
Yes.
And the patient can articulate, because they are experts. They've been through this.
Yeah.
One would say fentanyl, one would say hydromorphone, one would say, "Don't try morphine, give me hydromorphone," because that has been the experience. And it is these unique ways of managing these patients that can be challenging in having one size fits all kind of sort of protocol for a patient. And that's what our systems are failing to do. So there's a systems issue which needs to be tackled. And I'm encouraging our advocates, and you patients have been so powerful this evening, including Marianne, who really spoke so well about the pressures of caring for a child with sickle cell disease. It's you who have to be listened to. And I plead with the advocacy groups that the time for divisions should be done away with. We've been divided for so long, each group wanting to do their own thing. What we need to do is to bring the best of us, like Serena and others, who can articulate this message and do it loudly enough so that we are heard and listened to. The system is much more difficult to change than we think. It needs coordinated, sophisticated, well-oiled, well-organized advocacy. And I hope this session today was a part of it, because if ED physicians become our allies, I think it goes a long way to get what we are hoping for.
I think we're reaching the end of our time now. There are a couple of questions still in the chat that we didn't get to tackle tonight. And so we'll coordinate with CAEP to see about the best way to share responses to those questions as well. I think that this, the last discussion in particular, was a very good way to end off tonight. So an excellent reminder to all of us in emergency medicine about how quickly things can change for our patients with sickle cell, how important it is that we believe their experiences and that we take their concerns seriously. And how important it is that we work together with our patient advocates and with our colleagues in hematology to make sure that we're offering the best care possible. So thank you to all of our speakers and panelists tonight. I wish we could keep talking for hours and hours yet, and I hope I get to work with all of you more in the future. Thank you to everybody who signed in for the discussion tonight. I hope this was a useful hour to you, and I hope that this is just the start of conversations in emergency departments right across the country. A special thank you to CAEP for having the vision to facilitate a much needed national conversation about emergency department care of sickle cell disease. Please, everyone who's listening, please do take a moment to fill out your evaluation. You should see the link in the chat, and best wishes to everyone. Good night.